Now we're going to see Myasthenia gravis. Here the pathophysiology is we have antibodies against the nicotinic type of acetylcholine receptors on the post neuromuscular junction muscle. So here we have the neuron, here the synaptic buttons, here the synaptic cleft, or where the neuromuscular junction, and here we have the muscle, the acetylcholine receptors. Here we have an antibody against this receptor that produces two things. One is blocks the receptor, so acetylcholine can no longer bind to this receptor. So one is the blockage of the receptor. And second is that promotes the degradation of the receptors. So the patient would present with weakness on the musculature, not pain, but weakness. Usually bulbar weakness and proximal weakness. The patient would have difficulty combing, brushing teeth, sometimes the eyelids would be affected, so the patient would be or would have ptosis, the eyes would look like tired, and the patient would have problems chewing the food, and with the eyes the patient would feel that they are like tired. The most common muscle that is affected is the medial rectus of the eye, and sometimes this can present with ptosis of the eyelid, most common on just one side, or most notable on one side. Sometimes pseudo internuclear ophthalmoplegia, and the signs that we will see for the eyes, we have something called the hearing test or sign. This is, there will be one eye that has more ptosis than the other, so let's say that this eye has more ptosis. If we occlude this eye or we elevate the eyelid, we will see ptosis on this side. The other is the Kogan test. This is if the patient lifts up the let's say the eyes, so from the normal position ups the eyes or looks upward, then we will see that the eyelid will go upward and then will return. That is, there will be some moment in which the eyelid will have ptosis, but not at the beginning. The diagnosis is the best initial test is with the acetylcholine receptor antibody. Sometimes if we don't see this, we would do anti-smooth muscle kinase receptors antibodies or anti-MuSK. But the most specific test or the most accurate test is the electromyography. Here we are stimulating the muscle by stimulating the nerve, and if we see decrease in the amplitude or repeatedly decreasing, then this would be diagnosis of Myasthenia gravis. Additional tests, we have endrophonium test. Here we will give acetylcholinesterase inhibitors. So here we are giving a inhibitor of the enzyme that breaks down the acetylcholine. If the enzyme breaks down the acetylcholine, then there is no acetylcholine and the action is terminated. But if we inhibit this enzyme, we will have more acetylcholine here on this neuromuscular junction, and the patient will get better because we have more acetylcholine. Even though we cannot do anything with the receptors, we are increasing the concentration of acetylcholine. So if we see that the patient gets better with this endrophonium, then this would be a positive test, and so we could now go to the treatment. The treatment would be acetylcholinesterase inhibitors, but with a long life, like pyridostigmine or neostigmine. There's other test, that is, we would put ice on the eyelid, and if we see elevation of more than 2 millimeters, then is a positive test, and the patient has Myasthenia gravis. This is because the eyes inhibit the acetylcholinesterase, so it's kind of the same mechanism behind the endrophonium test. During the test with endrophonium, the patient can have other cholinergic effects, like lacrimation, sudoration, sweating, etc. So we would give atropine in order to prevent this, or we can just have atropine in order to treat it right away. The treatment is just the acetylcholinesterase inhibitors, but sometimes these are not useful, and in that case we would treat with cyclosporine, azathioprine, mycophenolate, mofetil, cyclophosphamide. Cyclosporine would be most useful, or azathioprine. This we would give it while we wean off the patient from steroids. Remember that sometimes the patient can have the crisis, myasthenia crisis, in which the patient has respiratory failure, complete tiredness, etc. This is life-threatening, and in that case we will give plasmapheresis or immunoglobulins IV. Sometimes the patient can have the myasthenia crisis because the patient is undertreated, and so in that case we need to go ahead and up the doses, increase the doses. The other issue is that maybe the patient is taking a lot of medications, and so there are a lot of acetylcholine here, and so the receptors are like desensitized, and so in that case we need to remove temporarily the medication. In order to distinguish between these two cases, is the patient has myasthenia gravis or is again with this symptomatology, so we would give again edrophonium, and if we see that there is no response, then that is because the receptors have been desensitized. We should be careful with medications. For example, there could be contraindications of medications used for other reasons, but in myasthenia gravis, like aminoglucosides because they produce blockage, penicillin, fluoroquinolones. These are the most common that would be contraindicated. This is associated, myasthenia gravis is associated with T-MOMA, the tumor of the thymus. So if the patient has this presentation, we need to do chest X-ray, chest MRI, chest CT scan in order to rule out the T-MOMA. Now, if the patient is not responding with these acetylcholinesterase inhibitors, if has less than 60 years and is post-pubertal, we will do thymectomy. And if the patient has greater than 60 years, we will give prednisone. Now, the thymectomy is, yes, certainly if the patient has the cancer, the T-MOMA, we will remove it, yes. But in case in which there is no cancer, anyway, we will remove the thymus because the thymus is where the B lymphocytes are producing plasmatic cells that then produce the antibodies that attack these cells. The reflexes would be normal unless on severe cases as opposed to Lambert-Eaton, and the myasthenia gravis we could divide it into 4 stages. One is just the ocular myasthenia and there is no treatment to be done. 2 is responds very well to treatment and there is just local involvement or generalized but don't severe. 3 is generalized with crisis, and 4 is the 2 or 1 that progresses to 3. And 2 can be divided into A or B. The B is not responding very well, etc. So this is myasthenia gravis. Now in the next video we will talk about Lambert-Eaton syndrome.